Respected chairperson, dear panelists, good evening. Welcome to my presentation. My topic is echocardiographic evaluation of tricuspid valve disease. So tricuspid valve is situated rightwards toward the mitral valve, and it is not continuation with the pulmonary valve. It has three distinct leaflets: anterior, posterior, and septal leaflets, and the leaflets are thinner than the mitral valve leaflets, and annulus is a bit larger than the mitral annulus, and tricuspid valve is apically situated than the mitral valve. So tricuspid valve is the game maker in complex congenital heart disease because tricuspid valve is situated apically. So with this location in complex congenital heart disease, it gives the identity of the right ventricle. You see this in this picture in a corrected TZA patient, as this is a tricuspid valve, so this should be considered as a right ventricle. So what we see in the echocardiography, we will see the leaflets location, thickness, mobility, and cooptation. In which view is best viewed in tricuspid valve? How to get right ventricular inflow views? In conventional pasternal long axis view, if we tilted the transducer towards the right hip, then in tricuspid inflow views visualized. This is the tricuspid inflow view, right atrium, right ventricle, and this is the tricuspid valve. So in pasternal inflow views, when the septum is visualized, visualize the septal leaflet and opposite is the anterior leaflet. If we tilted the probe inferiorly, then anterior and posterior leaflet have been seen. In apical four-chamber view, the leaflets could be visualized. Also, in apical four-chamber view, if you tilted the probe anteriorly, then we can visualize the septal leaflet and as well as the anterior leaflet. And then if you tilted the transducer posteriorly, then we can visualize the septal and posterior leaflet. In apical four-chamber view, we can calculate or you can measure the annular diameter of the tricuspid valve, as well as we can also measure the right ventricular diameters to see the right ventricular function. In pasternal short axis view, in the aortic level, we can also appreciate the anterior and septal leaflets of the tricuspid valve. In transesophageal echocardiography, in mid-esophageal level, in 0 degree, as we can see in four-chamber view, in this view, we can also appreciate the anterior and septal leaflet of the tricuspid valve. Also in 63 degree, mid-esophageal view, transesophageal echocardiography, you can appreciate at the aortic level, posterior and anterior septal leaflets. In 125 degree, near the bicaval view, we can also visualize the anterior and posterior leaflet. In 3D echo also helps to assess the tricuspid valve accurately. Now, tricuspid regurgitation. Mild tricuspid regurgitation in general is benign. Moderate to severe tricuspid regurgitation is associated with reduced long-term survival, even in the absence of comorbid pulmonary hypertension or ventricular dysfunction. So what are the causes of primary valvular tricuspid regurgitation? As we know, Avestein anomaly, carcinoid tumors, endocarditis, myxomatous degeneration, and rheumatic heart disease. As we know, in Avestein anomaly, there is a apical displacement of the septal valve, and also there is a cell-like anterior leaflet that is tethered in the RV and atrialization of the ventricle. In carcinoid tumors, there is a serotonin-like substance that causes the fibrosis, shortening, and restriction of the leaflets, make the leaflets a clap shape, and leaflets is a fixed in open position. Flail leaflets. In this picture, septal leaflets is flail and flail leaflets, there is a eccentric MR, and MR goes to the opposite, eccentric TR goes to the opposite of the flail leaflets. In rheumatic heart disease, as we know, tricuspid rheumatic heart disease, isolated tricuspid heart disease, rheumatic heart disease is rare. It is always associated with either mitral rheumatic heart disease or aortic rheumatic heart disease. And there are scenario like rheumatic heart disease, caudal thickening and commissural fusion, tip thickening, and there might be non-cooptation. What are the secondary causes of TR? When there is a annular dilatation, that causes the secondary causes of TR. Pulmonary hypertension, left ventricular dysfunction, left to right shunts, and right ventricular infarction. This is the pathophysiology. As we know, the intrinsic lung disease can cause pulmonary hypertension. Pulmonary hypertension can cause right ventricular dysfunction or right ventricular dilatation. As well as in left heart disease, then we can then left atrial pressure may be increased, left atrial fibrillation might be there. So that could affect the tricuspid annulus dilatation that ultimately produces tricuspid regurgitation. There are some special characteristics of tricuspid regurgitation jet, like this is early peaking and low velocity and dense Doppler envelope. So now assessment of the severity of the tricuspid regurgitation. This is important. By chamber dimension, we can also assess the if there is a right atrial enlargement or there is a right ventricular enlargement, that indicates the severe tricuspid regurgitation, as well as if we measure the annula, if annulus is more than 4 centimeter, this is also indicates the severe tricuspid regurgitation. As we know, interventricular septal flattening, that is D-shaped LV, either in systole or both systole in diastole, that respectively, that is pressure or volume overload. This is also indicator of the severe tricuspid regurgitation. And as Colonel Parashar sir also mentioned, that there is a diameter of the IVC if more than 2.5 centimeter or R area more than 18 centimeter square is also indicator of the severe tricuspid regurgitation. Jet area, we can calculate the jet area if it is more than 10 centimeter square, and vena contracta wide if more than 7 millimeter, this should be considered as a severe tricuspid regurgitation. In this picture, the jet area is 4.2 centimeter square. That is not severe, it is moderate tricuspid regurgitation. And also the vena contracta wide, but we have to take biplane and then average it. If it is less than 7, it is moderate tricuspid regurgitation. And hepatic and also systolic hepatic vein flow reversal. If there is a systolic hepatic vein flow reversal, if we put a pulse wave Doppler in the hepatic vein, if there is systolic hepatic vein flow reversal, that should be regarded as a severe tricuspid regurgitation. And PISA method, we can calculate the effective regurgitant orifice area and regurgitant volume. That is also indicated by certain parameter. We can calculate the severity. And few slides regarding tricuspid stenosis. Tricuspid stenosis is rare. It is almost always associated with rheumatic heart disease. They are extremely rare to find in isolation. And as it is associated with mitral stenosis, that both chamber might be dilated, and also there are features like mitral stenosis leaflet like commissural fusion, shortening and thickening of the tips and caudal thickening. So in Doppler echocardiography, we can measure the severity of the tricuspid stenosis. Is the mean gradient of tricuspid stenosis less than 2? It is normal. 2 to 5 millimeter mercury, it is moderate, and more than severe more than 5 millimeter mercury. So with this, I want to conclude, Mr. Chairperson, the prevalence and clinical impact of tricuspid valve disease was largely overlooked until recently. That's why it is called as a forgotten valve. So competence in echocardiographic assessment of the tricuspid valve is crucial to diagnose the presence, to see the severity, and to find out the etiology of tricuspid valve disease or tricuspid regurgitation. Accurate assessment is also useful to determine the ideal treatment strategy and device candidacy and support for percutaneous intervention. And lastly, careful evaluation of the tricuspid valve is required in patients undergoing mitral valve surgery to exclude the need for tricuspid valve repair. Thank you for your patient hearing.